Good afternoon, everyone. I'm really sorry that I cannot be there, but a last-minute health issue in my family prevents me to be in Rome. It's a real pity. It would be lovely to share with you and share with you a couple of days talking about PKs. However, the task is actually that I need to kind of review what happened in antiviral pharmacology in the last year. And after my potential disclosures, I had to start with the fact that I realized there are kind of guides on how to create a real review. But in the end, I decided that it's a very personal view. As you can see, it's going to be 99% about HIV pharmacology, because 20 minutes is going to be hard to just cover all the other topics. So I will start with DDIs, because I think one of the issues that came out recently and this year was actually something new about the interaction between dolutegravir and rifampicin. So this is just a background about the interaction that I'm aware that all of you are actually aware of in terms of how much rifampicin is able to reduce dolutegravir exposure after its induction effect. And also we know that WHO suggests to increase the dose dolutegravir to 50 milligrams twice daily to overcome this effect. However, there are some implementational challenges in terms that the availability of TLD is much higher than one of dolutegravir. And some studies suggest that approximately half of patients received the double dose rather than the usual dose when used with rifampicin. Also, if you take a look at phase 2, the study data, dolutegravir antiviral effect was actually similar between 10, 25, and 50 milligrams, suggesting that even the reduction we observed with rifampicin cannot be that relevant in patients that not harboring resistant associated mutations. And also, a study in Botswana, one of those suggesting that half of the patients were receiving the double dose, reported observationally that both TB and HIV outcomes were similar between the two groups, let's say. So it was published recently this year. The Radiant TB study is a phase 2b randomized double-blind study in which patients with TB and HIV were randomized either to receive TLD plus placebo or TLD plus an additional dose of dolutegravir. The study was small, 108 participants, but it was very similar to what was observed in real life, because as you can see, the CD4 count was below 200 and HIV RNA was above 5 log. So suggesting that actually it might represent what we can observe in real life. And this is what they observe in terms of proportion of patients with biological suppression, both at 24 weeks. That was the main endpoint of the study. But as you can see also with 4, 8, and 12, there's no difference between the two arms. And very importantly, no treatment-emergent dolutegravir resistant mutation were observed in the 19 patients in which a study-defined biological failure was observed. So I think this study has important implication for limited and intermediate resource countries, and there might be a discussion on what to do with dolutegravir dose in patients receiving rifampicin at the same time. We also received some data on how to manage what to do with long-acting cabotegravir-rilpivirine. And this is a nice model study in which inducers, rifampicin and rifabutin, were tested, and some strategies to overcome the interaction were tried in terms of modeling. As you can see in the red box, well, even increasing the dosing frequency of LA cabotegravir-rilpivirine was not enough to overcome the interaction with rifampicin. However, when administered rifabutin, the simulation suggested that administering long-acting cabotegravir-rilpivirine every month and giving also an additional daily oral rilpivirine dose of 25 milligrams was able to overcome this interaction. You see here the two boxes and here in the bottom right, comparing adding a 25 milligrams or a 50 milligrams every day was actually able to keep rilpivirine concentration above the threshold of 50 nanogram per ml. But so data on other DDIs might be interesting when we have to look at new drugs. This is kind of the table I use when I have to think of the new drugs and the metabolism and the potential for DDIs. And apart from lenacapavir, we'll talk about it a bit later, there are some data on fostemsavir that actually have a low potential for being perpetrator of DDIs because it's an inhibitor of OATP1B1, OATP1B3, and BCRP. Particularly, this is a study in which the PK of ethinyl estradiol and also the progestin are tested with or without fostemsavir. As you can see, the effect of co-administering fostemsavir is actually an increase of 40% of ethinyl estradiol AUC. So in the end, the author gives some recommendations suggesting that when co-administering fostemsavir with oral contraceptives, the estrogenic dose should not exceed 30 micrograms, and actually an additional caution should be advised in case of individual high risk for thromboembolic events that we know might be associated with estrogenic exposure. And finally, about the topic of DDI, I'm happy that it's one of the few studies in which new anti-cancer drugs are actually tested in combination with ARVs. In this case, efavirenz and ritonavir were tested as actually drug for seeing, since this drug is a CYP2A4 substrate, what was the effect of combining with these two antivirals. But since it's usually we don't have no data about anti-cancer drugs, especially with HIV, I think it's a good starting point to test the effect and the PK of these new drugs in our patients. The second topic is actually, I wanted to take a look at the new data we receive on long-acting cabotegravir rilpivirine since we started using it more and more in our patients. One of the important topic, and it's something we're going to discuss in the workshop since there are some interesting abstracts on this one, is actually how relevant is exposure of cabotegravir rilpivirine for the loss of biological control. So there was a previous analysis. This is the final one, let's say, on above 1,600 patients, was published this year, which the two models were prepared. One model with only baseline variables and one model in which PK was accounted for. In the end, the author suggested that the baseline variables could be important for predicting the risk of loss of biological control. But still, if you see here in the table, when we include cabotegravir PK at week 4 and 44, and rilpivirine PK at week 44, well, the risk of loss of biological control is high if the concentration are very low, but also you see that BMI disappears for the multivariate analysis. So PK seems to be one important point that may be associated with loss of biological control. We need to get more than that. I think we're going to discuss it through the workshop. But also we had the first, let's say, real-life data. This is the TDM registry of the Swiss HIV cohort in which we get some results from real-life patients in Switzerland. And they actually show that there's 13% of patients with low rilpivirine concentrations, but also there's one individual very low rilpivirine cabotegravir exposure. Interestingly, this was an athletic person injecting anabolic steroids, and so the hypothesis is actually that enhanced physical activity might result in greater absorption and therefore faster elimination of both drugs. Again, this is one of the topics I think probably we need to get more information on, but I think it's important to take a look at that. In the HPTN studies of prevention, this in case is HPTN 084, they also investigated which was the effect of delayed injection in women treated actually in prevention, in HIV prevention studies. I think it's important because we already have data on that in other studies, but I think it was nicely described. You see here in the bars that if you take a look at 3 months, 3 to 3 months and a half, 4 months, and also 5 months, that still the vast majority of patients have concentration above 4 to 8 times higher than protein-adjusted IC90. So at the end of this, the authors suggested that they're going to test giving long-acting cabotegravir as a prevention strategy in female every 3 months, so only 4 times a year. And I think it's also, again, a new strategy, a promising approach to HIV prevention with long-acting intramuscular tests. The last two things we actually received this year from the literature, the first one is which is the exposure of both cabotegravir and rilpivirine, where the injection are administered in time. And we actually received this PK data suggesting the exposure is pretty similar. but also that 1/3 of the patients prefer TAG injectors compared to gluten injection. And so it's good to have another option, and it's also good to take a look at the PK that is very similar. The last point on LA capital Ripivirine is about pregnancy. So again, since it's a new drug, I think it's very important to gather data on pregnancies. These are 25 pregnancies in all the female patients enrolled in the studies, and also in compassionate use. As you can see, the exposure persists for most women during the 3 trimesters, and the decay seems to be very similar to what is observed in not pregnant women. However, it's also important to take a look at what happened with the pregnancy outcomes. And apart from elective abortion and some miscarriages, and some of them are in the first trimester, 10 live births, and 1 had a congenital abnormality, basically congenital ptosis. So I think it's important to keep on collecting those data and get more safety signals in this population. The third topic is actually about other long-acting drugs. So this is one of my favorite studies at last CROI, is actually the combination of lenacapavir plus 2 bNAbs administered every 6 months in virologically suppressed people living with HIV. As you can see, the study is pretty small, so 20 patients in the end that reached week 26. But the results are promising, with 90% of them having an HIV RNA below 50 copies. And in the only patients with virological rebound at week 16, both bNAbs phenotypic susceptibility and capsid mutation were not observed. So it still retains susceptibility to the agent used in this patient. We still need to understand what happened in this case. For lenacapavir, also has some interesting data on DDIs. Actually, they are in the final prescribing information issue, in which, because we know that it's a moderate inhibitor of CYP3A, so when it's administered with very sensitive CYP3A probes, it might increase the dose. It is the case for midazolam. You see here the AUC of midazolam is increased 4 times. So we need to think in terms of the other drugs that might be affected by lenacapavir. And with the recent drugs, we're not using anymore to think about if our drugs can be perpetrators of DDIs. So it's important to bring in mind. But I think it's also the year in which much more data on bNAbs were released. We now have the data, the 2 data that I suggested before, in which PK was also good and reported to be good up to 26 weeks in the study. But we also have other bNAbs that have been tested both intravenously, subcutaneously, or intramuscularly. And if you take a look at this one in the middle, this is the one presented in this study, published in Lancet HIV this year, which we see there are different doses of these 2 bNAbs that are administered both subcutaneously and intravenously. If you take a look at the left part of this graph, you see that both these bNAbs maintain enough concentration up to 6 months, and they are both administered subcutaneously. So promising data on potential therapies that can be combined with other bNAbs of with other long-acting agents and just administered twice a year. So just, of course, it's an improvement in terms of PK and also what people might receive over time. The final topic I wanted to cover is actually about new delivery methods for the drugs we're using, actually. This is an interesting study presented at CROI, in which the implant is actually formed in situ. So it's actually combined of a polymer, a solvent, and cabotegravir. And after injected in the subcutaneous space, there's a generation of a solid depot. And after the depot is prepared, you see here, there's a diffusion-mediated release, but also a polymer degradation mediated that actually in the end releases the drug from the depot. Interestingly, in this preliminary study, the PK is good, but if you take a look at this one, you see that, for example, on 180 days, so at 6 months, still the concentration are very high, and they tend to plateau. But the good thing is that if you remove it, you see here what we found when we remove it, well, there's a decrease in concentration within 1 month. So, interestingly, so we need to remove it for any reason, including safety, pregnancy, or DDI. while the concentration gets to, let's say, to the safety threshold within a few weeks. There's also a way, and I think it's a field that Andrea Owen is the expert, but I just want to report the idea that this author tried to combine together using nanoformulation 3 drugs with very different PK profiles. In this case, TDF, 3DC, and dolutegravir, so TLD, one of the most used combinations in the world, actually combined together with lipid excipients in order to give a single subcutaneous injection of the 3 together. That was performed in non-human primates. If you take a look at the PK profile, you see here both tenofovir, lamivudine, and dolutegravir get to be a good PK profile. This is 700 hours. So in the end, the half-life of the 3 is much higher than before. For example, dolutegravir half-life is now 112 hours. And so I think it's a very good way of just trying to combine a full regimen in a single injection. We still need to understand the dose, side effects, etc. But I think it's a good, use of nanotechnologies for increasing the bioavailability of drugs. We also get the results of the subdermal inputs of islatravir. We had data from several CROI over time with these implants, but it was finally published, and 3 doses were tested in healthy volunteers for 12 weeks and then removed. And if you take the PK profile, the highest dose actually is the one with a better PK profile with sustained intracellular concentration up to 12 weeks, so 3 months. And again, here you see once removed that the drug concentration get to undetectable within let's say 4 to 5 weeks. So quick decrease in case we need to remove it over time. So again, once we see where everything is clear about the side effects of this drug, it's important to understand this PK profile. And also, they didn't see any association between side effects of lab abnormalities in the 3 according to dose and PK of these. And finally, always again on islatravir, this is the first modeling by Marcus Cardi's group in which microneedle patches were tested in terms of a hypothesis. And the hypothesis, the design of microneedle patches was actually as the surface should have been less than 20 square centimeter, and with repeated dosing above 12 weeks, so not less than 3 months. And the PBPK modeling was successful. And if you take a look at these with different bioavailability, we see when the intracellular concentration are still in the range of suppressing HIV replication. And if you see here in green box with 100% bioavailability, actually the concentration are really in the suppressing area, the suppressing range, even at 1 year. So these are good data supporting the development and advancement of microneedle patches for islatravir as a way of delivering for long-term administration. The last study I wanted to comment on HIV is the one in which we got the comparison of TDF-FTC versus an intravaginal ring containing tenofovir. So we have the data on the dapivir intravaginal ring. We have several other intravaginal ring in development. And I think it's important to understand which exposure is actually obtained and enriched in the tissue, and how much is the forgiveness of these in case subjects might have problems with adherence. I just wanted to point out here in the box, these are the intracellular concentration of tenofovir in ectocervical tissue, vaginal tissue. You see here in green is the oral administration, in orange is the intravaginal ring. You see here that the concentration are 100 times higher when an intravaginal ring is used. So supporting the high efficacy for prevention, but also the forgiveness in case the ring is removed or it's not timely administered. And also they also have an ex vivo study in which the tissue and fluids were taken out, and the ability to inhibit HIV once challenged ex vivo was tested, and as you can see, is higher for the red dots. That is actually the intravaginal ring. This is the last slide, actually the only study not about HIV, because I wanted to acknowledge the efficacy of the oral drug analog of remdesivir. So VV116 is actually an oral product of remdesivir, And it was actually tested in a large phase 3 randomized and inferiority trial against nirmatrelvir ritonavir in patients with mild to moderate COVID-19 at risk of progression. As you can see, median time to sustain a recovery, but the side effects were comparable. So it's important to have a new weapon against COVID-19 in the next season that's going to actually be here. So in conclusion, it was kind of hard in 20 minutes to review whole year PK. There's no time to talk about pharmacokinetics, loss of biological control in DDRs. There are some studies, obesity study, pregnancy. There's an interesting study in pediatric formulations. But also to just go through other antiviral drugs, we do have PK data on HBV, new HBV inhibitors, new SARS-CoV-2 inhibitors, CMV. There's also a new inhibitor of all arenaviruses, including Lassa virus. It's very important, I think, in the field of hemorrhagic fever. But I think I just focus on HIV. Well, the data on DDI are actually important for how to manage new drugs. And I think the rifampicin dolutegravir DDI has large implication for limited and intermediate resource countries. Several studies on long-acting cabotegravir pivirine. We still need to understand how much is important the exposure in terms of loss of biological function, and also trillion data on new formulation every 6 months, every year. We see what happened in the future, but they're really, really interesting. And my final message is keep on, the best is yet to come. And with this, I want to thank you for your attention. And I will virtually be with you in the next 2 days.